I will do this sitting down then. Thank you. So questions, please submit questions through the app. There are a few that have come through already, and for those of you who can't do it that way, we will the microphone. First question is for Dr. Ribot. Do you rehearse angio-suite protocol and procedure for thrombectomy preparation on a regular basis?
Yeah, well, we recently did a mock patient simulation. I thought initially, honestly, I thought that in a center like ours, in which we do over 300 thrombectomies, that would not help much. But no, I was wrong. We did both protocols, both pathways, direct to CT scan with a fake patient, and direct to angio-suite, and we learned a lot of things. And I think it's good practice to perform this kind of simulation probably once a year to make sure that everybody is in the same pathway and the newcomers are also fully aware that what is going on.
Next question is, do you go direct to angio at night? Is this 24 hours a day or just certain hours?
Okay, as I said, we tend to punish ourselves by finding evidence that being there is better for the patient, right? But of course, we only do this protocol when we are there before the patient. So at night, if we know that the patient is transferred from another center or is coming from far away, we try or we usually are there before the patient, and then we can apply the direct transfer. Otherwise, if the patient just shows to the hospital and we are not there, doesn't make sense not to take a conventional CT and imaging while we are getting there.
We have a question at the microphone. Not yet.
There we go. Can you
Yes.
hear me now? Yeah. Tom, I liked your talk and your slide that said disruptive technology. So in our center, can you hear me? Is that better? So your slide that said that this was disruptive technology, I thought was very interesting. One of the first VIS cases that we had, our neurointerventionalist called a spoke hospital and said, there's an elbow in your ER. And the ER physician's responses was essentially, your slide said, this is too fast, this is messing everything up. It's the opposite, right? No, it's helping everything. So can you talk a little bit about how you managed that and how you worked with your hubs to show them it really wasn't disruptive technology? But I agree with your statement, it's the new standard of care.
Right, it's a new standard of care. That's an interesting statement. That's certainly how we feel about it. There's no substitute for teaching. We meet every month. We review the relevant cases. And the key thing is that you introduce yourself to all your ER physicians. Now, you may have a locums person. We had a locums person in the other night who did not know what VIS was. And we have a little standard saying when we call down there now that we've trained all of our neurologists. So what's interesting, so it's really all about, it's about the training that you do, and everything we train is summarized on that one slide that I showed, which has the expectations. The key thing to remember is that VIS is not a diagnostic itself. It's an aid in the diagnosis. It's a screening tool. So it's very important that the hub hospital understands that they are responsible for the care of the patient. So we meet every month and we talk about that. Now what's interesting is our expectations of our clinicians is as follows. We have a stroke doctor in-house 24/7. They work 12 hours on and then somebody else comes in. We ask our doctors to respond back to the app within 10 minutes of every CTA coming from a spoke hospital, including our spokes and our non-Erlanger spokes. They don't have to respond to the CTAs coming over from our hospital because we're right there. But that lets everybody know what's going on with the patient. And if there is a CTA that's concerning, either a high-grade stenosis or a occlusion that's potentially treatable, then we expect our doctors to call them directly. So we're not relying on the LVO app to tell us that there's an LVO. We're actually looking at all of the images. So one thing important to remember, VIS is not licensed to deal with a proximal carotid occlusion. One of the things very important is that as you start getting into the business, you realize how little some of these spoke hospitals know about how to take care of stroke. For example, in a patient that has a high-grade carotid stenosis where the M1 is open, you'll see contrast in the M1, and we've had situations where the outside hospital thought that was perfectly fine. If there was contrast in the M1, there was nothing to do. Okay? You're not going to pick up an isolated ICA proximal stenosis on VIS with the LVO detection, but you will see it on your phone as soon as you scroll up and down. So we've picked up the first 2 cases that we intervened on. They were both proximal ICA stenoses that we brought the patients up emergently and intervened on them. So these guys really like us a lot. They've become our best friends. It does create some responsibility on our side, but it's really dramatically changing the care that's offered.
If I may, a follow-up question on that. I was going to ask about added staff in order to have this system that pulls patients in rather than waiting for them to be pushed out to you. Do you think it would work without an in-house vascular neurologist screening all those images?
So there I am flying to ISC. I'm at 40,000 feet over the Pacific. True story. And I'm responding back to an alert that came over my phone. So our system is, we're very busy like a lot of your centers are here. If our expectation is we expect them to text back through the app. If it is, we expect them to text back on every CTA. We can just say no LVO, or if it's a false positive, they say false positive LVO and they don't have to call. If it is a true worrisome CTA, then they have to call. But if our doctor on call does not answer back within 10 minutes, we'd like it 5, but if he doesn't answer within 10 minutes, then one of the other backup people that are watching answer back for them. True story, I'm taking communion between drinking the wine and putting the bread in my mouth. I answer back, and my son is here on the left, my wife is on the right, and she didn't even know that I answered back. So it really pulls the whole team together in a way I've never seen any other technology do. While VIS does not have LVO recognition on the CTA portion, keep in mind, just like Rapid, you can set the alerts with the thresholds, and you can see it. It'll alert on the CT perfusion. So this technology is coming a long way, and it really works surprisingly well. We're very impressed.
Thank you.
Thank you. Before we take that question, I just wanted to tell the audience there's a poll question out there for Dr. Taleb's talk to see how many of you use an LVO scale in your hospital systems. Your EMS uses LVO scale or not. So just a yes/no response, not particularly a question about the scale itself, and you would be able to see the responses yourself too. And a follow-up question with Dr. Taleb, just his thoughts about beyond LVO scales, scales that encompass posterior circulation, scales that encompass subarachnoid hemorrhages. How do we get all of this together? His thoughts.
That's an excellent question. So the group out of Japan actually started to do this. They, I think it was published in Stroke, I think 2018, where they actually had 20 or like, I think it was like 10 to 15 questions where they looked at the blood pressure, the symptoms, they asked 10, 15 symptoms, and they actually divided up into subarachnoid, intracerebral hemorrhage, or LVO, but there were more input points. So yeah, if your EMS is willing to do 15 points, you actually can start to make algorithms to tell the difference between ICH, subarachnoids, LVO, but it's all about getting enough clinical history and information reliably where you can do that.
In terms of the response to the question about the LVO screen, I'm not sure how to interpret this, but it looks like we've got 23 responses in the affirmative. That doesn't, I don't know if there's any negatives.
So I have a
Well-designed question.
I have a question in the audience.
yeah, I have a question about the skipping the ER. So one of the very can you hear me?
Lean in a little closer. if you could.
One of the pragmatic issues that come up is that if you skip the ER, then at least in our hospital, the patient doesn't have a bed to go back to in case there isn't an intervention. So you see, this raises a lot of quality issues and policies, traditional policies get disrupted where a patient then is free floating, doesn't have a ER bed or a hospital bed to go back to, and it causes incident reports and a lot of upheaval. So this, while should not be the reason, I think we have to think about how these pragmatic issues that are not so uncommon can be solved before we we can really implement this on a larger scale. I'd love to hear thoughts.
Well, yeah, in fact, you say that the patient doesn't have a bed in the ER, but literally, think about he doesn't have a bed. The EMS brings the patient in their own bed. They leave the patient in the angio suite or the CT scan, and they leave with the bed. So there is a complexity in organizing in the hospital that there should be a bed coming for that patient, literally, because yeah, you can find yourself stuck with the patient there. So of course, it needs to prepare the whole team. The ER usually, at least in our settings, they are happy to have less patients. They are usually overcrowded. So now, for the last years, they are barely seeing acute stroke patients, and they thank us for this. But I agree, you need to make it work, and it's not easy.
There's another question for Dr. Ribot. When you give IV TPA in the angio suite, do you stop the TPA when you open the artery mechanically prior to the end of the infusion?
Well, yeah, we can debate here. Usually, we just let it finish. But unless we felt that we might have harmed the vessel, dissected it, or obviously if we perforated it, we stop it. But usually the fact that we achieved a TICI 3 would not mean that we'll stop the TPA automatically.
Thank you. And the final question we have is, are you concerned about the short dwell time with TPA when administering at the time immediately before thrombectomy? I think that what's being asked is, do you feel the TPA has enough time to have any effect?
It's fine if it doesn't have time to have an effect. I mean, so that's excellent. The thing is, you give it in case you are going to have trouble getting to the occlusion, and you will not be able to immediately pull it out. But that's will be the best thing that can happen, that the TPA doesn't have time, right?
And I have one more question for Dr. Taleb about positive predictive value and negative predictive value. As you said, depends extremely on the prevalence in the community.
Correct.
Don't you think that those two values really need to be calculated for each community?
Well, the overall accuracy will change, because if you have something that's very specific and something that's less sensitive, and your prevalence is only 10% versus 40, yeah, it changes which tool that you use. And then another way to look at it, which the group out of UCSF did, is they looked at something called likelihood ratio, so positive likelihood ratio and negative likelihood ratio, meaning like if it's positive or negative. So yes, that's, I would agree. I mean, if knowing that, if somehow you can know the prevalence of LVO in your community, you know, depending if you're in Tennessee and you have tons of LVOs, it's 50%, or, you know, maybe you're somewhere where it's more lacunars, you know, because of hypertension or something, you know. But I think that's going to be very difficult. I mean, I don't know, maybe some of the stroke epidemiologists can like help us with this type of stuff, but I think it's very difficult to know.
Thank you.
Just one other comment about that. You made a great point before, which is if you're going to have high sensitivity, your specificity is not going to be as good, obviously, and that's how we want to tune it. So we're going to see a lot of false positive LVOs in whatever technology we look at. It's very, very important that everybody look at the technology from a critical eye and say, does this app or does this technology allow you to very definitively exclude that there's an LVO here? And there's a lot of variability in the technology that's out there doing just that.
Well, thank you.
Thank you very much, everyone. Another round of applause for the speakers. Let's go to our next session, which is acute care, and continue this conversation about large vessel occlusions as well as use of tenecteplase and role of the artificial intelligence. So the theme builds up in the acute care section and continues on from pre-hospital care. Let's invite our moderators. Dr. Andrea Alexandrov is here, and Dr. Siddharth Mehta are going to lead this session.
Okay.
Ask for the moderators.
All right. Thank you. All right. So perfect. Let's stay on time, and we're going to continue without a break until about 10:30. So hold on, guys. Our first speaker is Mark Alberts. Mark and I will go way back. This is the man behind Brain Attack Coalition guidelines, keeping them honest about new guidelines. And Mark is asking a question. Why don't we use tenecteplase for acute ischemic stroke? So why don't we, Mark? All right. Please do.